Good morning there. Do you hear me? Do you guys hear me? Hello? Do you hear me? Hello? Do you hear me? Rashma? Tinto, Rino, do you hear me? Guys, do you hear me? Okay, great. Today will be the fourth session of discussing our unit protocol for resuscitation. Remember in the first session we talked about the purpose and when we intubate resuscitation. And we've talked about training of NRP and how do we scoring. We talk about high-risk delivery. There is maternal condition, there is fetal condition, and there is antepartum complication and delivery complication. These conditions need to be attended by a pediatrician and nurses. And we've talked about, why we do resuscitations and why we anticipate that bad or unwanted outcome when there is a fetal compromise. We've talked about preterm infant special need and special challenges such as hypothermia or inadequate ventilation, about infection and organ damage of newborn baby, of a premature baby, and how to avoid that. We've talked about the antenatal counseling, meeting with parents, special premature situations, and talk with them, and that will prevent their complaint and increase their cooperation. We've talked about an overview, how to do resuscitation. We've talked the three first questions before starting the resuscitation. Is the infant term? Does he have a good tone? Or infant is breathing? And then we do the 30 seconds of first help, which is dryness, position, stimulation, suction, and so on. And then we've talked about after 30 seconds, we do heart rate and the breathing. If the baby is breathing or not, and if the heart rate below 60 or above 100 or between 60 and 100. And we said if it's below 100, then you need to do PPV. If it's above 100, then you don't need to do. You just need to send the baby with mom. If it's below 100, you need PPV, and then wait for 30 seconds of effective PPV, which means effective means that the baby chest is rising. After 1 minute, now only the heart rate. So remember, 3 questions, 2 questions, and only 1 question. The heart rate. Below 60, continue PPV with chest compression. Between 60 and 100, just PPV. Above 100, stop and wean the baby from oxygen. If at 1 minute, the baby goes instead of well baby care, after 30 seconds, then the baby goes to monitoring care, which is the same well baby care, but in addition, checking the vital signs. If the baby needs more than 1 minute, then he goes to intensive care. And we've talked about the initial step, how we do positioning, how we do dryness, how we do stimulation. And we've talked about keeping the baby always in transverse position with the head above the body and supporting the head. And we've talked strong stimulation are not allowed. If the baby cannot breathe by simple tactile stimulation, then you need to do PPV. And we said the stimulation only stroking the sole on the palm and rubbing the back, not abducting the lower limb, not squeezing the abdomen, not pincing the chest, and always be gentle. So we talked about the routine care. We've talked about those who need further management. And we've talked about if there is apnea less than 100, you need PPV. And if the baby is labored breathing and it's above 100, you might consider CPAP. And in premature babies, if they are more than 35 weeks, can be curbed in level 1, but if they are less than 35, then they need intensive care. We've talked about the temperature control, especially turning up the room temperature, and preparing the bed, warming the bed, preparing the heated mattresses, and so on, and minimizing heat loss by covering the baby and keeping the humidity, and so on. And we've talked about now we've reached to the airways. How we manage airways when we do resuscitation. So any infant required further interventions other than providing stimulation, dryness, positioning, and suctioning. First, we need to open the upper airway by putting the baby in flat position. And the baby should be on his or her back, inside a radiant warmer. The neck should be in a neutral position. How we know the neck is in a neutral position? The chin, the tip of the chin, and the tip of the nose should be at the same level, or what we call sniffing position. So when you sniff like that, where the chin, if you put your hand on the chin and the nose, it should be very horizontal. So it's slightly extended position, but not hyperextended. And then at the end of this protocol, there is a picture how to make that position, sniffing position. Again, sniffing position means the tip of the chin and the tip of the nose are on the same level. So a little bit extended neck, but not. And the baby should be on a hard surface, flat, and also inside a warmer. What means sniffing position? Means aligned. The posterior pharynx, the pharynx, and the trachea are all in the same level, which help to open the upper airway for air entry. Sometimes, very unlikely, you need to put a shoulder roll below the shoulder to help extending the neck slightly. Again, not hyperextended. Suctioning also can clear the upper airway before doing because it can prevent the obstruction and can help giving the PPV. Once you put the baby in a correct position and then you suction the mouth, then the nose, you can do that by bulb syringe or mechanical suction or even electrical suction. Anybody talked with you about this, referred him to me. So the suctioning is by bulb syringe or mechanical or even electrically delivered suctioning machine. You suction the mouth and the nose only. Remember, mouth and nose only. You don't need to go further inside. So you suction first the mouth and then the nose. Because if you suction the nose, the baby might cry and might be suction all the content to the airway. So remember, suction the mouth, it's like the alphabetical, M and then N, mouth, nose. Remember, mouth, nose, M, N, like alphabetical order. Suctioning of esophagus or stomach should be avoided and only indicated if the stomach are full for certain intestinal obstruction or whatever. Because suctioning means stimulating vagus and causing bradycardia and maybe apnea. You can sometimes wipe the mouth or the nose by a towel. So this is how you deal with the airways. Okay? And then you need, if there is a meconium stained liquor, the care should not be different from a baby with a clear liquor. Same. We used to intubate and suction, but that's not anymore. So it's the same general principle, whether it's a clear or meconium stained liquor. Now we've talked about pulse oximetry. Now pulse oximetry is very important to check the oxygen saturation of the baby and whether we need such oxygen or not. Remember, cyanosis is a very late sign, because cyanosis to occur, you need 5 grams. And if the hemoglobin of the baby, let's say 20, 5 grams is 25% of the 20, which means the saturation should be down to 75 until you see cyanosis. That's if the hemoglobin is 20. If the hemoglobin is 15, then you need 33%, which means the baby should be 67 to see cyanosis. So it's very poor indicator of oxyhemoglobin saturation. So you don't need to depend on, you need to connect always the pulse oximeter. When you connect, when you anticipate, even if the baby is okay, but if you anticipate that the baby might need resuscitation, connect. Whenever you give positive pressure ventilation, and if you see cyanosis, or if you want to give oxygen, so positive pressure, oxygen, anticipation, cyanosis, all these need pulse oximetry. It's better to put the pulse oximetry in the preductal, in right upper hand, or you can put it in earlobe if you can, but the best is the right upper hand. And when you do that, there is target saturation. So you don't expect that the saturation will go to more than 95 from first minute. So if you see saturation at 70, you don't need to give oxygen. You don't need to give PPV. It's just baby meeting the target. They won't reach the accepted saturation until 10 minutes. And remember, this is preductal. So if it's postductal, it's even lower. Now, how we give oxygen? So we talked about PPV, we talked about meconium aspiration and meconium staining, and we talked about how to give oxygen and how to monitor the oxygen, and now how to supplement the oxygen. So if the baby is more than 35 weeks at birth, you can start resuscitation with room air. What's mean start at room air? Mean the oxygen is blended. So you give a flow by medical air, and you give percentage of oxygen by oxygen. And then you mix them, you blend them, and then you have a flow and you have oxygen percentage. If the baby, however, less than 35 weeks, it's reasonable, might start somewhere between 21 to 30%. The younger the gestation, the more the percentage, up to 30% when the baby is 24 weeks. And why? Because oxygen is toxic. Oxygen has free radicals. Oxygen have oxidants. And all this are toxic to the body. The body needs to look towards for a long time to get rid of them. And it might contribute in sick babies to chronic lung disease. Once you start in room air in more than 35 or in 30% in less than 35, monitor the oxygen by saturation. And then titrate accordingly. I want to remind you of the importance of hyperoxia, exactly like hypoxia. The same consequences. So more than 30 weeks, you need 21%, less than 30 weeks, you need 30%, or somewhere between 21 to 30%. The oxygen target is 90 to 95%, depending on the gestation. So term baby, 95, but preterm baby is down to 90. How we provide positive pressure ventilation? When? We only need positive pressure ventilation if the heart rate less than 100. So after 30 seconds, you did your position, you did your warmth, you did your dryness, you suction, but still the baby less than 100, okay? Or he's not breathing, or he's gasping. And what is gasping means? Mean a breathing that is irregular without flow. So you see chest moving, but there is no actual flow. That's called gasping. So when you initiate positive pressure ventilation, if the heart rate at 30 seconds is less than 100, or the baby is apneic, meaning not breathing in 20 seconds, or he's gasping. He's breathing irregular, but only chest movement. There is no air entry. At that point, you initiate positive pressure ventilation. We usually use self-inflation bag, but if we have source of air compression and oxygen, we can connect to flow inflating bag. This does not need effective seal. This needs very effective seal. Or we can use the T-piece with the Resuscitation. So these are the three methods to give PPV. Again, you give PV only if the heart rate less than 100, or the baby is not breathing or gasping at age of 30 seconds after you did your 5 steps: dryness, suction, warm, positioning, and positioning, suctioning, dryness, warmth, and stimulation. And we've talked about each one. If the heart rate now depend on the type of the PPV, which one you are using, you can decide how much you deliver the positive pressure. So if the baby is, the heart rate is more than 100, and the baby is breathing, but the breathing are labored, or there is desaturation, you might consider to give positive CPAP instead of giving PPV. But if the baby heart rate less than 100, or the baby is apneic, or gasping, and they said gasping is breathing without air movement. At that point, you need to give PPV. But if the heart rate more than 100 and the baby is breathing but labor, then you need to give CPAP. And if the baby intubated, of course, PPAP. The best and easiest to use the self-inflating bag because you don't need air source. If you use 2-piece resuscitator, then you need to decide your PIP and your PEEP before starting giving the positive pressure ventilation. The difference between self-inflation and flow inflation, the self-inflation is self-re-inflating. So once you release your hand, when you do resuscitations, you need to deliver about 30 to 40 centimeters of water. And how you do that? You hold the bag between your 4 fingers and thumb. Each finger will provide 15 centimeters of water. So if I want to deliver 30, I use 2 fingers and thumb. If I want to deliver 45, I use 3 fingers and thumb. If I want to deliver 60, I use 4 fingers and thumb. So remember how to deliver the pressure. Okay? And you should not completely release the bag. You should always keep some pressure. So you don't completely deflate. You release your hand and complete inflation of the bag. You always have some pressure. Okay? And you don't make the bag completely empty. So you don't squeeze it fully, but you don't release it fully. And remember, each finger gives you 15 centimeters. If you cannot achieve the pressure, you can close the pop-off valve. You can close it or open it. If you close it, you completely. If you see the chest is not moving and you have a problem and you need more pressure, you can close the PFO. The pop-off usually open when you deliver more than 45. So if you deliver more than 45, it's open to release to prevent you causing pneumothorax. So remember, do not deflate the bag completely and do not inflate the bag completely. Remember, depend on the pressure you need, you use the number of fingers. What else here? The pop-up, we've talked about it. When you give oxygen, try to start with less than, if you're connecting oxygen to the self-inflation bag, start with, the minimum would be 1, and always start below 2 liters per minute when you connect the flow oxygen to the self-inflation or flow inflation bag. And start always in babies more than 35 weeks with 21% when you are blending the oxygen. If you're using more than that, then the baby is less than 35 weeks or less than 30, you use 30%. So if the baby term, I start with room air and then I go up. If the baby is preterm, I start with 30% and then I go down. Okay? So these are not important. What about the flow inflation bags? The flow inflating bag should be, or some people call it anesthesia bag, should be connected to flow. Otherwise, it will not be inflated. And in addition to the flow, it needs to be good sealed on the mouth of the baby to be inflated. And the flow inflation bag has a valve. Sometimes the valves are open and you need to close it by your hand. And sometimes there is actual valve. You can open it and close it, depend on the size of the inflation of the bag you need. So some organizations, they don't put this valve. They hold the end of the bag between the index and the thumb, and then they bag like this. I don't know if you see my hand or not. No, you don't see it. Let me see. So here you hold the end of the bag like this, and then you bag like this. Or sometimes there is a valve. You can close it, you can open it, you can open it lightly to control the pressure in the flow inflation bag. And then the valve or the bag should be connected to flow and should have a good seal. Without seal, face mask seal, the bag will not be inflated. The T-piece resus there, you need to set your PEEP. First you start to your PEEP, same knob, and then you close the opening at the antagonist end of the mask on the baby. So the mask on the baby, there is antagonist end, there is opening. You keep it open, then you control the PEEP, and then you close it to control or set the PIP. And then once you put your finger, you start to give PIP. When you relieve your finger, you are giving the PIP. So it depends on the duration that you want and the count. So 1, 2, and 3, or 1 and 2 and breathe, or 1 and 2 and 3 and breathe. Depend on you want it 40 or 60. So 1 and 2 and 3 and breathe, that's usually 40. 1 and 2 and breathe, that is usually 60. And also you control the duration when you put your finger to give the PIP. Sometimes the baby you cannot breathe and you don't have somebody expert in intubation beside you. So you might need to use LMA, laryngeal mask air MA, and this needs training how to insert it. And inshallah we'll do it at some point, how to insert an LMA. If there is baby you giving PPV, very unlikely that you cannot give effective PPV by the face and mask. And then you don't have somebody beside you who are expert in intubation, then you need to use the laryngeal mask airway. You need to know how to insert it. And if you don't know how to insert, and you don't have somebody to intubate, and the PPV by face and mask is not effective, you might need to give an airway. Very unlikely situation. Okay, so this LMA, how to insert it, there is a technique how to insert it. I will send a video, and then me and Ms. Ren will have some kind of workshop to tell you how to help you to how to use the laryngeal mask airway, the oral LMA, insert it in certain situations. So we've talked about position. The position should be neutral or sniffing position. And again, sniffing means when you sniff something where the tip of the nose and the tip of the chin are the same level. So it's a slightly extended, not hyperextended, where the oropharynx, nasopharynx, pharynx, and the trachea are in the same alignment to open the airway. Sometimes you need to put a shoulder roll below the shoulder to do that. Most of the time you don't need. Suction, again, we've said suction like alphabetical, so M then N, so mouth then nose. You make that you have seal, a good seal when you do PPV, and therefore you need an appropriate size mask. And the best mask will have a circular shape and have a cushion. So it can cover, you can cover from the bridge of the nose to the tip of the chin. You should not cover the eye, and you should not override the chin. So it should be from the tip of the chin to the bridge of the nose, avoiding the eyes. And when you hold like E and C, which mean your index and your thumb is on the mask and your 3 fingers holding the jaw. So index and thumb over the mask and the 3 fingers holding the jaw. The ring 5th fingers holding the chin. And always position the baby when you do PPV in, because always there is temptation to go to flexion. Always you need to remember to mildly extend or not hyperly extending the neck. So in the initial breath, as we said, you use your fingers when you bag by other hand. So if you use the only index and the thumb, you are giving only 15 centimeters. If you use 2 fingers and the thumb, you're giving 30. If you're using 3 fingers and the thumb, then you're delivering 45. And remember, when you squeeze, don't squeeze to the end. Keep some air inside. And when you release, don't release to the end. Keep some air inside. So you don't squeeze to the end. You don't inflate to the end. You don't release to the end. You always have some, because by doing that, you always provide people. And again, you can do 1 and 2 and breathe, and 1 and 2 and 3 and breathe. So that will decide how many events per minute you're giving. Remember to avoid excessive volume by turning on your pop-up valve. But if you are not having effective ventilation, you might need to close it to increase the pressure. You start with the pressure somewhere between 4 to 5 when you do PEEP, and then you can increase as needed. CPAP, sometimes you need to decide to give CPAP if the heart rate more than 100, the baby is breathing but is labored or he's sinus. Okay, and I'm going to finish here until because we reach intubation. If there is any question, I can answer. And you can unmute yourself and ask me a question, or you can text me if you have any question. Any question? No? Questions? Okay, so we'll go to the next. I will not give every day. I will make it every other day, so I don't want to overload you. So the next session will be Thursday, inshallah. Okay?
Okay, thank you, sir.
Thank you very much. Have a good day. Bye-bye.